Welcome, 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 everyone. Thank you for joining us with such good energy around peer respite. We are so excited to share with you the results of our 2023 feasibility study recommendations report to help share the all the power and potential of peer respite and what it could mean for Central Maryland. So as we get started, we have an amazing team here of experts, and we're all going to introduce ourselves. So take it away, Travis.
Hi, good morning, everyone. My name is Travis Atkinson, and I'm a crisis systems consultant with TBD Solutions. I was proud to work on the Peer Respite feasibility project last year with this team, and it's great to be here today, and I'll turn it over to Cherene.
Thank you, Travis. Hello, everybody. Good afternoon. I am Cherene Caraco. My pronouns are she and her. I am a psychiatric survivor, and I'm the Chief Executive Officer of a peer-run organization in Charlotte, North Carolina called Promise Resource Network. And I was also just so honored to work with this team to come to Maryland and do the feasibility project. And it's great to see everybody again. And I'm going to pass it on to Dan.
Thanks, Cherene. Hi, everybody. Good afternoon. My name is Dan Rabbitt. I'm the Policy Director here at Behavioral Health System Baltimore. BHSB, for those who don't know us, is the local behavioral health authority in Baltimore City. We're an independent nonprofit, and we were able to work with On Our Own to help make this project possible. So really happy to be here, and pass it back to Katie to keep us moving.
Oh my gosh, everybody thrilled. I'm Katie Rouse. I'm lucky every day to serve as the Executive Director of On Our Own of Maryland. So On Our Own is Maryland's statewide consumer network. We are peer run, which means everyone on our team and a majority of our board have lived experiences with behavioral health challenges and recovery journeys. We were thrilled to work with these experts last year to really dig into the power, potential, promise of peer respite. And today we're going to share some of this information with you. There's a lot. We're going to pack as much as we can into 1 hour, but good news, we've got a website that's got all sorts of details that you can access to learn more about our study. So today we're going to briefly look at what is peer respite in real life. How does it actually function? What does it look like? We don't have peer respites in Maryland, but we have an expert with us who's going to guide us through that. We're going to talk about the study, what we did, what we looked at, all the factors and activities involved. And then we're going to explore what is the potential impact of bringing peer respite to Central Maryland. What will that mean for people seeking support in behavioral health crisis? What can that mean for our continuum of care? Then we're going to talk about some of the nuts and bolts of peer respite, things that we've thought through in our recommendations, but also things that we hope all of you think about in terms of how peer respite could come to your community. And then we're going to talk about some next steps. So with no further ado, the reason that we're all here today, what is peer respite? And for that, we're going to turn it over to our expert, Cherene.
Thank you, Katie. And some of you have been through the presentations that I have done, or you've seen some of the videos, you've been a part of these meetings, or you have seen online a little bit about peer and respite. So I'm not going to go too much of a deep dive, but we do want to create the foundation to make sure that we are all have some shared understanding of what we mean by peer and respite. So as you can see by the picture, a peer-run respite is in a house in a neighborhood, and we are going to talk a little bit about the different values or circumstances that a peer-run respite is operated through. It is an alternative to emergency departments, to involuntary treatment, to inpatient settings, and it is utilized when people are experiencing mental health related crises. And so when people come to our peer-run respites and walk around, I let them know this is a crisis alternative. This is a crisis space. So what we're accustomed to understanding in terms of crisis stabilization units or inpatient settings or emergency department, a respite is a version of that in a healing environment. So next slide, and I'll talk about a few of the components of a peer-run respite. So as I said, it is in a home, in a neighborhood. It's really important that it is not on a unit. It's not in a psychiatric hospital. It's not on a campus. That is intentionally a part of the approach because we know that spaces that are designed for healing and wellness yield better outcomes. It supports us to work through emotional distress in a safe environment. And so the environment is really important within a peer-run respite. On the right-hand side is a picture of one of our bedrooms in our peer-run respite, just to give you a visual sense. It is unlocked voluntary and non-coercive. And this is a really important component of what makes peer run respites different, but also make them successful. So when I say unlocked, what I mean is we do not lock people into bedrooms. We don't lock people into the spaces. So if you're used to sort of a traditional crisis setting where somebody can be locked in to a facility or a unit, or their bedroom is locked by staff, this is actually quite the opposite. It's more like a hotel where a person has their own locks to their own bedroom and they make a decision about who comes in and out. That's a really important component because we have so many folks that are in very traumatic experiences or have experienced a lot of trauma. So to have that safety and that protection and that personal space and privacy is one of the keys. When I say it's voluntary and non-coercive, I mean that as authentically as I possibly can say. Meaning we don't even want people to say to folks, well, you can either choose to go to the emergency department or you can choose to go to the respite. That in of itself feels coercive. We want to make sure that people are choosing to come to the peer run respite because they feel like that is the environment that will help them through the crisis and in which they will thrive. The approach in the space is completely not non-clinical. It is operated and staffed completely by people with lived shared experience in crisis environments, people that have been involuntarily committed, hospitalized, all of the continuum of being a user of crisis systems are the folks that operate and staff the respite. So it is not clinical in any way. It is very intentionally trauma informed in our language. Even the colors in the space, the way the space is designed, the way that it is set up is all designed around healing, recovery, wellness, and trauma informed. And as I said, it's peer operated. One of the interesting components about a peer run respite is oftentimes when people go into a crisis setting, the rest of their life has to be on pause, meaning they're locked into a space. They have to leave work for the period of time that they're there or leave school. They don't have a lot of connection to their family, their pets, things like that. In a peer run respite, it's actually the opposite. Somebody can be experiencing a crisis and make a decision that they don't want to compound their crisis by having to leave work or take time off of work. And so somebody maintains their employment if they would like to. They can maintain their school calendar and schedule if they would like to. The relationships they have with family and friends continue. On the other hand, somebody may choose, I want to take a break from all of it, and that's okay too. It is not a predetermined decision. It is something that truly is decided by the person. The length of stay varies. Some respites are 3 days, 7 days, 14 days. We've seen respites as high as 30 days. On average, what we find is that people stay at our respites around 7 days. But the ones that we operate here in North Carolina, people can stay from 1 to 10 days, and that's selected by the person. That can be extended as well based on what the person needs. The operating costs depend on a couple of different factors. Number one is because it is in a home, what is the cost of the real estate, the purchase of the house, the size of the house, the number of guests. To give you a sense, we just purchased our respite house in Raleigh, North Carolina. That house was around $620,000, has 4 bedrooms, has 3 bathrooms. We find just on average, the actual cost of running a respite is around $150 a day per person. If you look in our state, the average 1-day stay of an inpatient stay, it's around $2,400. So the cost is significantly different between a peer run respite. And when we look at the outcomes, in general, a 70 to 75% reduction in further use of intense crisis services and systems is one of the outcomes related to peer run respites. We see a reduced use of emergency department and a rehospitalization. Obviously, the costs are better. The engagement in community is better, and people self-reporting them feeling comfortable and confident to work through a crisis is also one of the outcomes. Next slide, please. So I think next is the pictures. So I want you to picture what it's like to go into emergency department, or if you have been hospitalized or you've been in those environments, think about what visually those places are designed, what they look like, what they feel like. And then I want you to go kind of the opposite and look at these pictures with our PRN respite. This actually whole slide are different pictures of one PRN respite that we have here in North Carolina. You're gonna see the top left corner, bottom right corner are two of our living rooms. We have the middle picture is one representative of the bedrooms. The way we have the bedrooms is that everybody has a queen size bed. It is their own bedroom. Nobody shares a room. It is set up, as I said, with a key fob on the outside so people can choose their code and they can make sure that their privacy is honored. Every bedroom for us has a white noise machine, has Wi-Fi, extra linens, has a lockbox for any personal items, and a mini fridge. We have updated kitchens, which I think is really important. My team hears me say this all the time. Everybody deserves beautiful spaces. And unfortunately, when we come into treatment programs, oftentimes we're staying on cots, we're staying on hard plastic surfaces, we are in sterile environments, and those things do not promote healing and well-being. Soft surfaces with a lot of attention to colors, to the way it's laid out and designed, to what's in the space and what's not in the space, both inside the house and outside of the house, are really important. The next picture is a picture of the Kiva Center. I think it's one of their respites, and you're going to see very similar. It's a house in any neighborhood, in any community. The last count that I had is we were up to maybe 64 peer-run respites in the country. I can tell you that, I know, isn't it mind-blowing, Katie? That number is increasing significantly. We have ourselves been asked to open 5 more peer-run respites. And so that in itself blows my mind, because it took me 6 years to get the people convinced that this type of crisis alternative is safe and it's effective and it's necessary in any community. Now it is caught on. People have seen the outcomes in our state, and we're being asked to open 5 more. And then we are seeing crisis peer-run respites open all around the country. So it's definitely both a trend as well as something that is becoming more valued. Next slide, please. So I get this question a lot. Who comes to a peer-run respite? I can tell you for us, it really is quite varied. We physically, where we are in our state, we are in a gateway for human trafficking, very unfortunately, a lot of sex trafficking. So we've had many guests come that have been survivors of sex trafficking or fleeing those type of situations. Most, if not all, of the people that come to our respite have experienced trauma. Is all over the map in terms of childhood trauma to currently having to survive in poverty, living on the streets, various degrees and experiences with trauma. We have a good number of people that come to our respite that are talking about self-harm and thoughts of suicide. So that is one of the main reasons actually people come to our peer-run respite. We also have folks that may be voice hearers, may have some high intensity experiences or what they would describe as unusual experiences, hearers, seers, sensors, people that have different life experiences that may feel distressing or may not feel distressing, but they just want another way to work through that what they're experiencing. Lots of folks that don't meet medical necessity for other crisis services or have experienced so much institutional trauma that they're unwilling to voluntarily go to a crisis setting. We want to prevent involuntary treatment as much as we possibly can. It has the least, it's least effective, most expensive, re-traumatizing for so many folks. And what we find is people would rather come voluntarily to that type of space than to risk being involuntarily committed to a psychiatric hospital or emergency department. And then, interestingly enough, we have a lot of working professionals that come to our respite. So I say this, we have a number of teachers that will plan their breaks to come to the respite. And when people ask me why that is, I say, think about any of our professional lives and experiences and the fear that we are going to be devalued, that our integrity is going to be questioned, that we are going to be locked up against our will and potentially lose our job. That is the experience of many first responders, of many teachers, people that work with the public. And there is a fear that if I am hospitalized, I am going to lose my job. And so people will preemptively choose to come to the respite when they are struggling or when they have a break to prevent that from happening. Next slide, please. Okay, I'm going to pass this on to you, Katie.
You might be thinking, oh, I missed a part of it. You know, how does a peer run respite work? So good news for you. This is not the only time that we've talked about peer respites in Maryland. Cherene, Travis, and I, Dan, we did a great symposium just a little more than a year ago, and we've got the YouTube video of that entire symposium, but also shorter videos from peer respite operators, including People USA in New York and Kiva Centers up in Massachusetts, explaining how their respites work. And then we had this phenomenal conversation between Cherene, Vesper from Kiva, Steve from People USA, talking about all the questions people ask, right? Of like how respites really work. What do you do in this kind of situation? So that's that FAQs video at the end. It's all on our YouTube channel at On Our Own of Maryland, Inc. Strongly encourage you check it out. There's a lot of great detail and real honest conversation that I think helps to illuminate people's questions about like, but how does respite deal with this situation? Or, but what do you do when this happens? And it's so inspiring and refreshing to hear these three leaders, these pioneers of respites in different areas, explain just like calmly, clearly, with a lot of support and hope of how crisis is supported in a respite. So you can find all those videos on our YouTube channel. And then also, we're going to move now into, we've talked about peer respite in general. Now we're going to talk about the work we've done in Central Maryland. So for that, I want to pass it over to Dan at BHSB.
Great, thanks, Katie. And again, welcome everybody. It's very inspiring that got 100 people joined in this webinar today. This feasibility study came about from some funding that BHSB received from the General Assembly and the Maryland General Assembly in 2022. Maybe hard to remember, but there's actually a lot of budgetary like flexibility and opportunity right after COVID, and BHSB came into some funding that was flexible. And we were intrigued by what peer respite was, and we wanted to drill down more into like, what is this really about? What would it take? And specifically, what would it take here in Central Maryland to establish something like this? Next slide, please. And why were we focused on Central Maryland? BHSB, we are the local behavioral health authority in Baltimore City, but we also were the regional administrative manager of another innovative grant that was supported by what has affectionately been called GBRICS, the Greater Baltimore Regional Integrated Crisis System Partnership. There's 17 hospitals that came together in 2019, 2020 to apply for some funding around innovations for the crisis system. And so BHSB was awarded, and our many partners were awarded this grant for $45 million to create a regional crisis system for Central Maryland. Central Maryland as defined by that map there with those 4 jurisdictions. And we focused on a regional call center with 98 expanded mobile crisis teams that were civilian only. So no law enforcement co-responders as part of those teams. More ready access to same day, next day appointments, and a big community engagement and outreach component. We could see that a peer respite program could fit into this continuum well, and could help us to achieve our goal of reducing unnecessary ED use and police interaction for people experiencing a crisis or other type of mental health or substance use distress. So we were intrigued. We thought it fit well with what we were already doing. And we were thrilled to be able to work with Katie and her team and On Our Own and her wonderful team on the Peer Respite project. So that's how we got here. And I'm going to pass it back to Katie, I think, to take us through what we found with this feasibility study.
Absolutely. Thanks, Dan. BHSB, just what a leader in terms of thinking of, how can we improve our system so that we're providing the right support to the people at the right time when it's being asked for in the way that really addresses crisis and healing from crisis. So in terms of the study, this took place between basically December 2022 and June 2023. And it had several phases. We, Honor of Maryland, here, we reached out to experts we knew we needed, Travis and Cherene, to bring in their expertise around crisis service systems, around peer respite and peer-run organizations. So throughout the period of study, we had over 250 touch points with community members because we wanted to know, what does the Central Maryland community want out of peer respite? Where are the needs? Where could this fit? How can this help enhance what we're able to offer folks who are experiencing crisis? So we did a symposium, we did a bunch of focus groups, we did key informant interviews with representatives from different parts of the system and different parts of the Central Maryland region. And then we went to go visit 5 peer respites across the East Coast with teams of people from our community engagement. So representatives from Baltimore City, Baltimore County, Carroll County, Howard County, so that we ourselves could go and experience what it is like to go to the retreat at the plaza, or what it is like to enter a peer-run respite. So we looked at respites that were funded in different ways, located in different geographic areas, operated by different kinds of agencies. We were very glad to have partnership from the Department of Health in being able to access data about crisis system utilization. So we could look at the numbers of how our crisis system is working, where were there gaps and opportunities. And then we had a lot of great conversations and a lot of support from the BHSB team, especially from Dan, to think through how we wanted to make recommendations about what we could do in Central Maryland that appreciated all the work that's being done right now to enhance our crisis system, where peer respite could go, and to really set a vision for what this could look like, over the next 10 years. And along with that came a business plan, because having a vision is one thing, having a plan, being able to go to a funding agency or a policymaker and say, here's how we know we can make it happen based on how it is happening. And you said, Cherene, over 60 other peer respites that are operating around the country. So you might be thinking, that sounds like a lot of work. It was. We were so proud and happy to be able to do it. And now we can share it all with you. So if you go to our website, honoronmd.org, you go to projects and trainings and look at projects, you're going to see a panel for our peer respite study. From there, you can get to our recommendations website. It's a whole website that just takes the information from the report and makes it a little easier to access. So you can break down, you can look at quotes we got from interviews. You can look at some of the graphs about crisis system utilization. We'll touch on some of that today. You can download our business plan and look at what the steps of implementation are that we see. So I hope that you do explore this website. It's a great resource just for learning about sort of how do we understand, how do we wrap our minds around the crisis system in general and what it looks like from all these different perspectives. So we're so just thrilled to have been able to support this effort. And now we want to make sure that we are sharing it with everyone here, because the truth is this has to be community driven and community led. So with that, we talked a lot about what peer respite is. We've explained how we came to this point in time with the knowledge that we have. And now let's look at, okay, so now what? What can this really do? And for that, we want to turn it over to our friend Travis.
Thank you, Katie. So for those of you who have only heard of peer respite now, hopefully you're feeling some inspiration or some encouragement. And if you've already heard about peer respite, hopefully this is just restoking a flame inside of you. It's important to remember that peer respites are sensible solutions to mental health crises that people are experiencing in communities all across Maryland and all across the country every day. It is a little countercultural to what we're used to. It is not a model that is based only on risk and only on making sure that the worst doesn't happen. It's based on people's experiences and recognizing the importance of social healing in the context of a mental health crisis. So let's talk a little bit about impact and a little bit about the landscape of data around Maryland and some important considerations there. Next slide. So in an ideal crisis continuum, you have typically 3 steps or 3 areas that you focus on. Someone to call, someone to respond, and somewhere to go. Now, if you look at the darker green circles on the bottom half of this graphic, you'll notice that these are the traditional places that people in a mental health crisis have turned to, because these are safety nets, these are systems of care that we developed over the last 75 years for people experiencing a medical crisis or some type of emergency. And so we see that that person in crisis can call 911, that 911 can dispatch EMS or police. People can also go to the emergency department directly or through those channels. In some cases, if there's a criminal offense that's been committed, people might go to jail. And then those might all lead to an inpatient psychiatric stay. Now, think about that voicemail message on your or maybe the answering machine of your doctor, your primary care physician, your nurse. They say, if this is an emergency, hang up and dial 911 or go to your nearest emergency room, right? We unfortunately hear that also on our therapist's voicemail. They send us to these same places when really we need answers and solutions that are designed for us, designed for people in a mental health or substance use crisis, not just sending people to the place where others go for medical emergencies. And so that's where we've seen the development of this top half of the graphic, this lighter green, where we have crisis call centers, 988 centers, which can then help to dispatch a mobile crisis team. And then from there, we have this somewhere to go category. And there's a number of services that fall underneath that umbrella, such as psychiatric urgent care, 23-hour observation, partial hospital programs, crisis residential programs, and peer respites. And when those options are exhausted, then psychiatric inpatient could also be one of those choices. But what we know in Maryland is that this somewhere to go category is important and probably not as well developed as some of the other categories. And peer respite obviously falls right there. But what differentiates peer respite from some of these other crisis services or these medical emergency services is that you can often go there directly without needing a referral from somebody else. Somebody else doesn't have to diagnose you or tell you what if you've met a certain amount of criteria. That's a direct conversation that can happen with the team at the peer respite. So when you are able to utilize these services, which by the way, not only are they effective in getting people the care that they need, sometimes they provide the care without needing to send you somewhere else. So a good 988 center or a good crisis call center can help someone in emotional distress or in crisis without having to even use a mobile crisis team or go to the emergency department in about 80% of the cases. And the same goes for a mobile crisis team. A good mobile crisis team can evaluate, de-escalate, and help a person 70% of the time or more, which means that the prevalence of individuals going to the emergency department can decrease substantially if they have a behavioral health emergency, or the reliance on some of those other places like hospitals, crisis residential programs, 23-hour observation, that can also drop. Next slide, please. So if we look at emergency department utilization here in Central Maryland, I want to draw your attention to a few things. First of all, you see Baltimore City, which has a high population, also has a high utilization of emergency department visits for mental health conditions. Now, it's important to know that about 12% of emergency department visits nationally are for behavioral health emergencies, substance use or mental health. So another interesting number to look at here is that you also can see the blue or the green bars on the bottom that kind of say per 100,000 people, how many people are going to the emergency department. So what that means is that Baltimore City not only has a high number of people because of their high population, they have a high rate of people that are going there. So even if everybody had the same population, Baltimore City would be having a higher number or a higher percentage of people going for mental health visits compared to those others. And then if you look at the statewide average, which is over there on the left, excuse me, you can see that the prevalence rates for Carroll County are similar to the statewide average, and for Howard, they're lower than the statewide average. So it would be interesting to look at what community supports are available in Howard County, or preventative efforts that are in place that maybe decrease the need for a mental health emergency department visit. But another important consideration is that when a person goes to the emergency department, their chances of being hospitalized in an inpatient psychiatric setting increase or skyrocket dramatically. We have heard in some instances that while a mobile crisis team in the community can divert people from going to the hospital in about 70% of the cases, if you go to the emergency department, you can only be diverted about 20 to 30% of the time. And part of that has to do with risk. Part of that has to do with some laws around emergency departments, which I won't get into today. But as we'll see in a couple of slides, the evidence actually shows that pure respites reduce the incidence or the reliance on emergency department utilization. That's amazing. If a person can stay out of the ED to begin with, and they can go directly to a place that is helpful and healing, like Cherene described, how much better is that for the person who's being served, which should always be our primary concern. But then how much better is that for everybody else who's involved in the system? The social workers who are trying to find a placement, the hospital who have less it's a less busy environment, so they can focus on other people's needs, and maybe needs that they're more skilled at. Next slide, please. Okay, so now we're going to look at utilization of crisis residential services, emergency departments, and inpatient utilization. And if you're not familiar with crisis residential, I'm glad to be here to briefly explain it to you, as I'm one of the founding board members of the Crisis Residential Association. Basically, crisis residential is an alternative to psychiatric inpatient, in which, similar to pure respite, people are in home-like environments, and they're being served for a length of time anywhere from 5 to 10 days on average nationally. And so, similar to pure respite, crisis residential programs demonstrate outcomes of equal or better client satisfaction and clinical outcomes at a lower cost compared to psychiatric inpatient hospitals. So both crisis residential and pure respite are important components of a well-functioning crisis system, as we saw on that ideal slide. So if we look at the data, we'll start on the left side here. The individuals served by each crisis type. We see those emergency departments, again, leading the way, 7,500 people served in an emergency department in fiscal year 22. And you can see a lot of people were served by inpatient psychiatric hospitalization. So if if every inpatient hospitalization came from an emergency department visit, then we could say about 6 out of 7 or 85% of those visits were originated from an emergency department. Now, that's just a speculation. We're not saying that that's the cause here right now. But you can see that if you had a higher utilization, let's say, of crisis residential or of pure respite, you're going to see those inpatient numbers go down. Now, why is that good for the community? Well, we know that an individual who is hospitalized once has a dramatically higher prevalence of being hospitalized multiple times in their life. So avoiding inpatient hospitalization, if it's for the right reason, if it's because you have options, it can be a good thing for somebody. And being in healing environments, being in unlocked settings, which most crisis residential programs are across the country, that matters too. That lowers something that we call iatrogenic harm, which is the harm that's caused by a system that is intended to help people. So if I was getting a surgery and the surgery was done on the wrong organ or the wrong part of my body, that would be iatrogenic harm. In the same way, that happens in our behavioral healthcare system, where people in crisis get bad treatment, which makes the crisis or the trauma worse. So we want to avoid that. So then we can look at spending in this pie chart here. Inpatient hospitalization, $117 million. That's a lot of money. That's money that, if we could decrease the utilization of those services, could be invested into other less coercive or less restrictive services as well. Let's go to the next slide. Okay, so I am not a researcher, but I am a research lover. And The great thing about peer respite is that it can appeal to your heart. It can appeal to that feeling that this is the right thing to do, but it can also appeal to your mind and to your logic. And in this case, we have a number of research articles published by people like Leisha Ostro, which say that peer respites lower hospital and healthcare costs. They give people a greater optimism about recovery while also reducing symptoms like depression and anxiety and increasing hopefulness, as well as increasing self-direction. So we have this body of literature now that says this is a good idea. This isn't just good to do because it seems like the right thing to do. It is the right thing to do. It's proving to be the right thing to do. Next slide. Okay, so I'm going to walk you briefly through some math here. I know this is the real reason why y'all came here, but let's make the case for why peer respites can be so helpful if we can open up our minds to the idea that a person in crisis can be served in a lot of different ways, not just by going to the hospital. So if a person in crisis calls 911 and an ambulance gets dispatched to their house, then they take that ambulance to the emergency department. So at that point, they've already incurred a cost of about $700. And this is according to some Baltimore County ambulance cost reports that an average ambulance ride in Baltimore County is $700. Then you go to the emergency department, and some data from the Maryland Public Behavioral Health System from fiscal year 21 and 22 tells us that the average ED visit is $1,450. And then from there, you go to the psychiatric hospital. Perhaps you stay there for a week or so. But according to Optum ASO claims from the same time period as the ED, the average stay can cost about $18,300. You add all those up, we're talking about a $20,000 experience, over $20,000. Now, what if we can remove the ambulance ride? What if we can divert somebody from the ER? And what if we can get someone directly into a peer run respite to stay for about a week or so? That cost for a week is going to be $2,500. And peer run respites are typically funded through local, county, or state dollars, so that cost is not passed on to the individual. Okay, the stay is paid for, but still the cost to the system is so dramatically low compared to that traditional path. So if we can do this 200 times a year, and you remember we looked at that data, we had thousands of psych inpatient visits or stays. So if we could take 200 and save that much money every time, almost $18,000 every stay, we're talking about a savings of $2.5 to $3.5 million, maybe even up to $13 million for each respite that's doing that across Central Maryland. That is exciting, and these are just based on actual numbers that are reported about the cost of these services. So we can do it because it feels like the right thing to do, but we should do it because it is the right thing to do from a logic perspective of still keeping people safe, making people feel seen, and doing so in a cost-effective way. There are so many benefits to thinking differently about behavioral health crisis from the lens of a peer respite. And I will turn it back to Katie.
Oh my goodness. I hope everyone's hearts and minds are just aflame with the potential, the possibilities here. If you are a research lover, if you are a math nerd, if you are a systems geek and you'd like to dig in, with thanks to the administration for, being able to supply us with some data, on our recommendations report website, you can dig in to the different charts and graphs that are in the report to kind of understand like what is going on. And we also highlight some of the important advances that are happening in Central Maryland, like the 911 diversion project, right? Trying to take folks who are calling 911 for behavioral health, redirecting to 988, the expansion of mobile crisis. So we also recognize that in the sort of pandemic and post-pandemic world that we're in, we want to always put that data in context. Like things 988, launched like just before we were doing the study. So there are things that are changing and happening. And yet we've got such potential to take a little bit of money, put it toward funding peer respites, a little bit of money in the large context of things. You want to make sure peer respites are appropriately funded. But what could the savings be? And not just in 1 year, right? For 1 year's worth of visits that were diverted. What does that change for the trajectory of people's lives? When we were in Massachusetts at the Kiva Centers, we were speaking with one of the staff members there who came to become a staff member, a peer support specialist, because she had gone to the respite. And she talked about how many times in her life she had been hospitalized in a state psychiatric hospital, and added up how many thousands and thousands of dollars that had cost the state for her to go back and forth to the hospital multiple times. She went to the respite. She experienced real healing. She got connected with a peer support community. She found a new identity as a peer supporter, hasn't been back to the hospital, right? Like what does that change look like? So it's not just the snapshot of sort of this data, this study today, but what does it mean for the ultimate transformation in our lives and for our communities? So with that, we're going to spend the last quarter of our time together just sort of addressing some of the logistical elements that came through and some of the things we learned as we went along on the path of looking at the data, visiting these other respites, talking with community members about, what you need and want. So they say in real estate, right? Like location, location, location. That is absolutely true for peer respite as well. And the most important piece of that is peer respite as a standalone can only do so much to create a healing space for that couple of days someone's there. Peer respite needs to be part of a continuum of peer recovery services linked into a network of peer support services. In Maryland, that looks like our wellness and recovery centers, right? Our recovery support centers. The peer networks that already exist here that can be enhanced and expanded. So for a respite to truly blossom, it needs to be within a network, a community network of recovery support services. Also, it needs to be connected to all the community resources. We had a lot of questions in our FAQ video, if you watch it on YouTube, about what happens when someone is unhoused and they come to the respite, right? Respite's a short-term stay. You're there for a week, maybe a little less, maybe a little bit more. So the respite also needs to be well connected with all these other community resources to help someone maybe start their healing journey of recovery, or to help meet needs that become driving forces for crisis, right? A lot of times our crisis is happening because of some life stress that is happening. And so how can we help people connect folks, or help to connect with other resources available? Also, a huge part of respite is the neighborhood. I know Cherene spoke really beautifully and maybe will again about just the intentionality of engaging the respite as in the neighborhood with the community members. It's, mental health is not a secret. We are all impacted by behavioral health, whether we ourselves have used services or have a family member. And so just creating that really strong bonds and support in the neighborhood, supporting the respite, supporting people who are coming there to stay for healing. Along with that, literally, where is the building? What are the qualities of the building? What are the qualities of the furnishing? That respite has to be a place of safety and sanctuary. And that also means knowing that it's going to be a welcoming space for anyone to come to that respite, that the community around is one that's affirming, diverse, welcoming, supportive. And then finally, you got to deal with zoning. And so we do have a section in our report where we address some of the basic zoning considerations, but ultimately what comes up is those are conversations that have to be worked out in the local context, which is also why it's so important for decision makers to learn about the promise of peer respite, to see where are there opportunities for us to make sure that our laws and regulations are supporting this type of transformative program. Next thing, logistical considerations. So peer respite works when a community, understands the value, trusts in the quality of services, and can help people connect to the respite. How many of us knew about respite right before we somehow got involved with behavioral health? If it's your first time experiencing a behavioral health crisis, you probably don't know what a respite is yet, unless we all do our jobs really well, and then everybody will know what a respite is. So there has to be a lot of work built up in making sure the community understand what a respite is and isn't, so we can help people connect to the respite so those direct conversations can take place, like Travis was saying, of, is this a place I could plan to stay? Maybe I work it into my WRAP plan. Maybe I work it, in as on an anniversary of a traumatic event where I know I'm going to have a tough time. I do every year. So I'm going to try to plan a respite stay at that time to get some healing support. We need to make sure that the policies and procedures encourage, embrace, uphold that choice-based process. It's never you go to the respite or you go somewhere else. That's not a choice. So that it is a truly voluntary path. We talked already a little bit just about the importance of housing. I think we all know there's an affordable housing crisis in our country, certainly in Maryland, whether we're talking about affordability or quality. And so wanting a respite to be open and available to anyone who wants to come and is a good fit for the respite, that also means helping people link up with housing options for after the respite stay is finished. And then that last piece about length of stay, just recognizing that when you're in a healing environment, it's amazing how, I think, Cherene, you put a great comment in the chat about like how dramatically that can shift. And a short stay can have exponential impact. So it's not that everyone who comes to a respite, has to stay for 7 days, can't leave before, can't stay longer. It really becomes customized to what that person's individual needs are and what the respite can do in the community. If we have one respite in Central Maryland open to anyone in the community, we're going to have so many folks, right, trying to come in and stay. Of course, we want everyone to. If we had 10 respites available, then there's also more flexibility because there's literally more spaces for people to be. So length of stay and capacity of the respite, how many there are, also have a clear link. And then the last thing, just a couple notes, are about the organizational, operational structure and the way the peer respites are funded. And for our study, we looked at respites that were run by provider organizations that leveraged some Medicaid funding. We also look at respites that were funded almost outside of the behavioral health system, county funding, and that were, peer-run, non-clinical, totally independent alternatives. So I'll speak for myself. What I found is that there was a palpable difference just in every way of the energy between a respite that is run by a peer-run organization and a respite that was being staffed by peers, but maybe was under the auspices of a clinical organization. There are different pressures, policies, procedures, regulations that clinical organizations are held to or feel held to, compelled to. And in peer organizations, we are very much have a flexible meeting people where they are, I think, creative approach, and that allows us to provide support in a different way. So the structure of the organization, right? We want peer-run spaces, fully peer-run spaces for respite, but we also need for that funding to be flexible. The organizations we found that did utilize Medicaid funding had to, it ended up really putting pressure on the way the administrative burden for their staff teams was intense and took away from time that could have been spent supporting people with peer support in the respite. But also it put a lot of pressures on having to think about who was invited to stay with the respite and who wasn't, how long someone could stay, because they constantly had to be navigating like what the cash flow situation was from Medicaid versus centers that are operating on grant funding, state funding, advanced cost-based reimbursement funding, prescriptive payment funding. Just we're able to flexibly meet those needs better and be able to welcome in people to the respite who really were being turned away or not eligible for other types of services and supports. Running a respite is 365, right? It takes a strong organization to do it. And not every peer support specialist is going to have a happy, healthy work experience in a respite. It is a high intensity crisis support situation. It requires a lot of intensive ongoing training, a lot of operational support in there. And so making sure that there is the right level of support for the folks providing support in the respite from the community, from the way it's funded, from the internal operations, that's really and truly key. So the last piece, and then I'm going to ask Cherene if you have some, since you're doing it in real life in North Carolina, running multiple respites, just the value that comes out of peer support, whether we're thinking about the value for like individual experiences, for our continuum of care, dollars and cents, back in the pocket of the community. The value of it happens because we are driven by our values. And so peer respite needs to operate from a point of mutuality, of connection, of recovery in a peer-run, peer-led space, that's what produces this incredible value. So Cherene, yes, please, with all of your wisdom and experience, what can you tell us about running a respite?
There is so much, and there's so much that you shared. You know, we took a lot of great intention to really gather information not only from our peer-run respites that we operate, but others around the country, look at some of the national data and the research, and then examine it from the lens of being in Maryland and what your landscape looks like, what your resources are, where your gaps are, to come up with this report, which I know for myself, I won't speak for all of you, I'm really proud of. Saying that, there's a lot of nuances to be able to do it well, and it's not an easy environment that is for everybody to work in. Part of the reason as human beings is we are either, I don't know if we're socialized this way, or we are trained this way in some ways or another to go to extremes. And so I saw somebody put in the chat that they saw some houses that were very, very structured and very, you know, people felt like they were in jail when they were there. That is one end of the extreme that we have a tendency to do to people is create and impose external structures because we have been taught that that's what creates safety. That's what reduces risk. That's what treatment looks like. That's what we do. And there is a lot of influence to have those environments be utilized, or to impose those type of environments in something like a peer-run respite. It will not be successful if you operate it like that. The other extreme is, oh, anything goes. We're just here to love people, and we're going to support everybody, and we're going to support each other as a team. And it can be too casual, where somebody working in the respite forgets that you're at work and you are here to support the community, and we can get stuck into supporting one another. And so I say that in the most delicate way that I can, is this idea of the right person working in the right environment. The organization has to truly value a healing alternative and be really great at that organizational structure, investing in your team, having the right combination of team, and recognizing when things are going to one extreme or another. It's very challenging to stay in the gray. But to do peer-run respite well, you are living in the gray. People are choosing how long they stay. You're not imposing that. You don't have the locks on the doors to say you can't get out and you have to get permission of when you're going to eat dinner. That's an example of that one extreme of Uber structure. On the other hand, people can't just decide, oh, I'm just going to roll in at 2 o'clock in the morning and maybe stay for an hour and then roll back out, right? That's way too much flexibility, because we have people that are experiencing crisis situations that really need that stay, that could be taken up by somebody who really is not utilizing it to what it was designed to be. So there's a lot of intention that goes into operating it well. Travis, I think you came off of mute. Did you want to add something to that?
No, I think it was really great. One quick point I want to make, Cherene, that you brought up during the project was that peer respites can actually bring a sense of peace and harmony to a neighborhood, or complement what's happening really well. The peer respite that Cherene opened up in Charlotte was previously an Airbnb that had a lot of woo girls doing bachelorette parties and whatnot, and inevitably the cops were getting called quite a bit. Peer respites like Cherene's, when they're intentional in the community and you're trying to be a good neighbor, actually can be a value add, and that can address some of the NIMBYism stuff. There was one question in the chat, Katie or Dan, that I just want to direct your way, which is how can viewers of this webinar best support the movement locally in Central Maryland?
Oh my goodness, that was thank you. What a perfect tee up in every way. So what are the next steps for this? So, you know, our vision would be that there would be 5 peer respites running in Central Maryland over the next 10 years. That we wanted to put a bold vision forward that we think is accomplishable, but will take all of us working together to help raise awareness, to raise support, to have great conversations with decision makers around policies, funding, you know, how can we, and with that, Central Maryland is a diverse place, right? Like deep in rural Carroll County, in the middle of Baltimore City, and Howard County's got, you know, suburban areas and rural areas. Baltimore County, same. what works for a respite in a community is specific and local to that community. The principles, the guiding values and principles are the same, but every community is going to have its own patterns. We already saw that in terms of like how people are or aren't using crisis services. What is, how are we going to find a space, make a space where everyone feels comfortable to come? So the most important thing we can all do right now is talk about peer respite. Everybody call 10 friends and say, did you know about peer respite? This exists all over the country. We don't have this here. We need this here. We want to create a groundswell of energy for this type of program to come to Central Maryland. So that's one thing that just you can do with your friends and family, folks you're working with, is just let people know that this is even an option. That's the first step, is can we see the vision in our mind? Next is, if you are engaged with a behavioral health advisory council, right, a local community, local community organization or council, recovery systems of care, right? If you are engaged in behavioral health leadership, bring up peer respite. Like, we want to bring this here. How can we do it? So that we are talking to decision makers who can help us navigate all of these pieces that have to come together. Where's the funding? Where's the location? What's up with zoning? There's one-time costs like acquiring a building, and then there's the ongoing costs like making sure that the peer supporters who work in the respite earn a wage that is appropriate for their expertise and their hard work, and that supports that ongoing training development. Because like Cherene was saying, like you have to live in that gray area, and that takes a lot of energy to do that well and to sustain that healing environment. And then the next piece is making it real, right? In our report, we have a business plan, which comes with implementation. And the recommendations we're making is that there's a planning phase that needs to happen for several months to pull all the pieces together. Then there's a launch of the pilot organization, the pilot project of the respite that needs to operate for a couple years. And then we can start the replication process. So along with that, it is also, we want peer respites to be operated by peer-run organizations. So if you work for or connected with a peer-run organization, the next question is, what are your needs as an organization that have to be filled in order for you to take on the project of running a respite? Many of our peer-run organizations are not funded the way they need to fully realize their potential. This is true in Maryland as well as across the nation. We've, Cherene, I know you talk with a lot of peer respite operators. And so that's the other question, is how can we support the peer-run organizations in our community so that they are ready to take on a respite and make that a reality for us. So please stay in touch. Hopefully everyone on this webinar got an email from Peer Respite at Honor of Maryland. That's where we're collecting, information, and we hope to send some updates out soon. We'll follow this webinar up with a link again to that recommendations report website where you can dig into all the details. With that, I think we're over time. I just want to thank our wonderful presenters, Cherene and Travis and Dan. I want to thank BHSB for their strong leadership, support, and partnership in this whole process. I want to thank all of you for taking an hour out of your day to join us in imagining what we could do next with peer respites in Maryland. Thank you, thank you, thank you.